Every 40 seconds in the United States, someone, somewhere, has a heart attack.
Yeah, it's a terrifying statistic.
It really is. Every 40 seconds. I mean, it's one of those numbers that gets thrown around so often, it almost, I don't know, it kind of loses its impact, right?
Right, it just becomes background noise.
Exactly. We always picture the dramatic cinematic moment, the clutch of the chest, the ambulance sirens blaring.
A Hollywood heart attack?
Right. But what if I told you that the most dangerous element of heart disease isn't necessarily the cholesterol circulating in your blood, or even the genetic history you inherited from your parents?
Oh, this is the part that always gets people.
Yeah. What if the most dangerous thing is actually the microscopic, like 8-point font printed on that folded piece of paper stuffed inside your pill bottle?
It's a terrifying thought, but honestly, from a clinical perspective, it is remarkably accurate.
Oh, wait, really? The paper is that dangerous?
Well, the ignorance of what's on the paper is. The biological pathology, the clogged artery, is only half the battle. If you don't understand the actual tools you're using to fight the disease, well, the disease just wins by default.
Wow. Okay, welcome everyone to another deep dive. Today, we have a massive mission.
We really do.
We are taking on a huge, culturally loaded, and honestly life-altering question based on a foundational text we're looking at today called the iMedix Protocol, Unpacking and Reversing Heart Disease.
Right, and we're combining that specific text with the broader data ecosystem of the iMedix platform itself.
Exactly, which is this incredible, fully independent medical information resource that focuses really intensely on medication safety, complex treatment questions, and deep-level patient education.
Yeah, they are essentially building the infrastructure for an informed patient. Because right now, I mean, the modern patient is drowning in data, but completely starving for actual context.
Okay, let's unpack this, because just looking at the title of this protocol, Unpacking and Reversing Heart Disease, I immediately have a problem.
Oh, what's the problem?
Well, reversing heart disease is like the holy grail,
Yeah.
right? It's what every single patient listening to this wants. But unpacking sounds like, I don't know, we're moving into a new apartment or something.
Right.
Why that specific word? Why not just say treating and reversing?
That's a great catch. It's because the authors of the protocol understand something that the general public desperately needs to realize.
Which is?
That heart disease, as a broad cultural term, is practically useless.
Useless. How so?
It is just far too broad. We throw the term around at dinner parties as if it's one single, simple phenomenon, like catching a cold or getting a broken arm.
Right, you just put a cast on a broken arm.
Exactly. You don't unpack a broken arm. The bone is snapped. You cast it, you heal.
Huh.
But heart disease is an umbrella term for a highly complex web of completely distinct biological failures.
So there are different types operating under the same name.
Yes, you absolutely cannot reverse what you haven't meticulously unpacked first.
Okay, so if a patient goes to their doctor and just hears, you have heart disease, that is basically like a mechanic looking under the hood of your car and saying, well, you have car trouble.
That is the perfect mental model.
I mean, it could be your fuel line is clogged, or your battery is short-circuiting, or your engine block is cracked, or your door literally just fell off.
Right. And the treatment for a clogged fuel line won't fix a dead battery. So to even begin talking about reversal, we have to define what part of the car is actually broken.
Okay, let's define it then. What are we looking at?
Broadly speaking, the protocol demands we separate this into 4 major categories.
4 categories, got it.
First, you have coronary artery disease, or CAD. This is the classic plumbing issue. This is what, 90% of people picture when they hear the words heart disease.
Right, the clogged pipes, the plaque buildup.
Yes, but let's look at how those pipes actually clog, because it's not just sludge sticking to the inside of a tube like grease in your kitchen sink.
It's not.
No, the biology is much more aggressive. You have LDL cholesterol particles circulating in your blood, and when there is damage to the inner lining of your artery, the endothelium, from things like high blood pressure or smoking, those LDL particles slip inside the wall of the artery.
Inside the wall, like into the lining itself.
Exactly. And your immune system sees them as foreign invaders. So it sends white blood cells called macrophages to eat the cholesterol.
Wait, so my own immune system is causing the clog?
In a weird way, yes. The macrophages basically gorge themselves on the cholesterol until they become these bloated, toxic things we clinically call foam cells.
Foam cells, that sounds gross.
It is. They die and pile up inside the artery wall, creating this highly inflamed necrotic lipid core.
Yikes.
Yeah, and your body tries to wall off this toxic dump by building a fibrous cap over it. That entire structure right there is the atherosclerotic plaque.
Okay, so the artery is narrowed.
It narrows the artery, yes, but the real danger isn't just the narrowing. The real danger is if that fibrous cap ruptures.
Oh, like a pimple popping.
Essentially, yes. If it pops, the highly inflammatory contents spill into the bloodstream, your body instantly forms a massive blood clot to seal the rupture, and boom, the plumbing is completely blocked.
And that's the heart attack.
That is a heart attack.
Okay, that is honestly terrifying. So that is category 1, the plumbing, coronary artery disease. What is category 2?
Category 2 is heart failure, and it is entirely distinct from CAD.
See, the term heart failure sounds like the heart just stops completely. Game over. But that's not what it means clinically, right?
Not at all. Sudden cardiac arrest is when the heart stops. Heart failure is more of a mechanical and structural exhaustion over a long period of time.
So it's still beating.
The heart hasn't stopped, no, but has become a profoundly tired, inefficient pump. And this usually happens in one of two ways.
Okay.
The first is systolic dysfunction. So over years of trying to pump against high blood pressure, or maybe after surviving a massive heart attack that killed off a section of the muscle, the heart dilates.
It dilates, like it stretches out.
Yeah, it balloons out, the walls get thin and floppy, and it becomes too weak to squeeze the blood out effectively.
So going back to the car analogy, the engine just loses all its horsepower.
Precisely. The ejection fraction, which is the percentage of blood pumped out with each beat, just plummets.
That makes sense. And the second type?
The second type of heart failure is just as insidious. It's called diastolic dysfunction. In this scenario, the heart muscle actually becomes too thick. It hypertrophies. The walls become incredibly stiff.
Wait, hold on. Isn't a thicker muscle a stronger muscle? I mean, if I go to the gym and lift weights, my biceps get thicker and stronger. Why is a thicker heart muscle bad?
It's a great question, but you have to remember the heart isn't a bicep. It's a chamber meant to hold fluid.
Oh, right.
If the walls of that chamber get too thick and rigid, the heart can't relax. And if it can't relax, it can't fill up with blood between beats.
Ah, I see.
So it might squeeze with plenty of force, but it's squeezing an empty chamber. The blood backs up into your lungs, which is why heart failure patients often feel like they're literally drowning when they lie down at night.
Wow. That's awful. Okay, so we have the plumbing, which is CAD. We have the mechanical pump exhaustion, which is heart failure. What is the third category?
Arrhythmias. If CAD is the plumbing, arrhythmias are the electrical grid.
Okay, the house wiring.
Right. Your heart has its own internal pacemaker called the sinoatrial node. It sends a beautifully synchronized electrical wave through the heart muscle, telling the top chambers to squeeze, and then a fraction of a second later, the bottom chambers squeeze.
Very coordinated.
Very. But in conditions like atrial fibrillation or AFib, that electrical grid just goes completely haywire.
The wiring of the house starts short-circuiting.
Exactly. The upper chambers, the atria, stop getting a clean, single signal. Instead, they get bombarded with chaotic, rapid electrical impulses.
So what happens to the muscle?
They stop squeezing effectively and just start quivering. Now, you won't necessarily drop dead from the quivering itself, but because the blood isn't being squeezed cleanly out of the top chambers, it pools.
And pooling blood is bad.
Very bad. When blood pools, it clots. If that clot gets pumped out of the heart and travels up to the brain, you suffer a massive stroke.
Man, so the electrical problem in the heart creates a plumbing problem in the brain. That is wild.
It's all connected.
And the final category?
Structural heart disease. This involves the literal architecture, the doors, hinges, and walls of the house.
Like the valves.
Exactly. We're talking about valvular diseases, where one of the 4 one-way valves in your heart might be prolapsing, meaning it's leaking backwards.
Oh.
Or it could be stenotic, meaning it has become calcified and narrowed so the blood can barely squeeze through.
Are there other structural issues?
Yes. It also includes congenital defects, like having a literal hole in the wall between the chambers that you were born with.
Okay, so going back to our mechanic analogy, you really have to know if you were dealing with a clogged fuel line, a cracked engine block, a short circuit in the dashboard, or a broken door hinge.
Yes, absolutely.
Because if you don't unpack that specific issue, you can't even approach the second word in the protocol's title, reversing.
Exactly. Reversal is a massively powerful word.
It really is.
It implies going backward in time to a state of pristine health. But because we just established 4 entirely different categories of failure, Reversal means radically different things depending on your specific diagnosis.
But doesn't the internet essentially sell reversal as a one-size-fits-all miracle? I mean, you go online and see these articles like, reverse your heart disease in 30 days with this one weird fruit.
Oh, constantly.
Or the hidden secret cardiologists don't want you to know to clear your arteries. They treat the biological complexity with, like, total disrespect.
They do, and honestly, it is actively dangerous. The iMedix protocol is incredibly careful to define what reversal actually means in biological reality, precisely to combat those oversimplified claims.
Well, let's define it.
Let's look at coronary artery disease. Can you reverse CAD? The answer is heavily nuanced. If someone promises you that drinking celery juice will dissolve the plaque and make your 60-year-old arteries look like they did when you were 10, they are lying.
No magic juice. Got it.
Right. But we can achieve what is clinically called plaque stabilization and, in some cases, mild plaque regression.
Okay, explain plaque stabilization, because earlier you said the real danger was the plaque popping like a balloon. So how do we stop the bomb from going off?
Through aggressive medical therapy, typically high-intensity statins combined with profound lifestyle changes, dietary shifts, and cardiac rehabilitation.
Okay, and what does that actually do inside the artery?
When we do this, we are fundamentally altering the biology of the plaque. We actually shrink that toxic lipid core I mentioned earlier. We draw the cholesterol back out of the artery wall.
Really? It can come back out?
Yes. And at the same time, these interventions calm the systemic inflammation, which allows the body to build a much thicker, harder, fibrous cap over whatever plaque is left.
So you aren't making the bump inside the pipe disappear entirely, but you are turning it from a fragile, explosive water balloon into like a hardened patch of concrete that won't pop.
That is exactly what you are doing. You are rendering the disease dormant. The goal is profound risk reduction and halting the progression of the disease.
That's huge.
It is. That is a form of functional clinical reversal. You have reversed your risk of dropping dead tomorrow.
Okay, now contrast that with heart failure. Can you reverse a ballooned, exhausted heart muscle?
In many cases, yes. We have incredible medications now, things like beta blockers, ACE inhibitors, ARNIs, that actually alter the neurohormonal environment of the body.
What does that mean, the neurohormonal environment?
Well, when your heart starts failing, your body panics. It thinks, I'm not getting enough blood, I must be bleeding out.
Makes sense.
So it dumps adrenaline and other stress hormones into your system to force the heart to beat faster and harder. In the short term, this keeps you alive.
But long term?
Long term, it is like whipping a tired horse. The adrenaline is literally toxic to the heart muscle cells over time. Medications like beta blockers shield the heart from that toxic adrenaline bath.
Oh, wow.
Yeah, when you protect the heart from its own panicked nervous system, it can actually heal. A dilated heart can sometimes shrink back to a normal size and regain its pumping power. We call this reverse remodeling. That is a measurable biological reversal.
But then if we look at structural disease, say I have a severely calcified narrowed aortic valve. I can't reverse that with a diet or a pill or cardiac rehab, right?
You absolutely cannot. You cannot meditate, fast, or eat enough spinach to dissolve severe calcification on a physical hinge in your heart.
Right.
That requires a mechanical intervention like a surgery to replace the valve. And this is why unpacking the diagnosis is a literal matter of life and death.
Because if you guess wrong...
If a patient with severe valvular stenosis reads an article about reversing heart disease naturally, stops seeing their cardiologist, and relies on garlic supplements, they will eventually go into irreversible heart failure and die.
Oh, yeah.
It's a fatal misunderstanding of what category of disease they possess.
So treating heart disease without unpacking the specific details is like trying to repair the foundation of a house while you're still throwing a party inside.
Exactly.
You have all these guests, which are your daily stressors, your diet, your blood pressure fluctuations just running around, and you need to understand exactly what tools you're using before you start knocking down walls. You can't just swing a sledgehammer and hope for the best.
I love that analogy because the sledgehammer approach is how so many patients approach their treatment. What's fascinating about our sources today is that they establish this staggering biological complexity, but then they immediately pivot.
Pivot to what?
The protocol doesn't just stay in the sterile realm of cellular biology. It zooms out to look at the human element, the safety, the understanding, and the application of the medications used to achieve these clinical reversals.
And that pivot makes perfect sense because the desire for reversal is so immense. It's emotionally potent, you know.
Completely.
A patient hears they have a chronic disease, they panic, and their intense drive to fix the problem drives them to seek out numerous treatments simultaneously.
Yes, the shotgun approach.
Exactly. They are prescribed 3 medications by their cardiologist, then they buy 5 different supplements from a health food store, they alter their diets drastically, and this desperate shotgun approach leads directly to the biggest obstacle highlighted in the iMedix data, which is severe, life-threatening informational blind spots.
Yes, because the true battleground for patient health right now isn't just taking place in the arteries or the left ventricle. The battleground is in the information.
The information gap.
It is in the massive, terrifying gap between what a medication is chemically designed to do, what the clinical data says its risks are, and what the patient actually understands when they swallow that pill at 7 o'clock in the morning with their coffee.
Right.
If you lose the battle of information, you lose the biological battle by default.
Which brings us to a massive structural problem in our healthcare system. The peril of patient misunderstanding.
A huge barrel.
A central factual pillar of the sources is that people fundamentally misunderstand medication risks, leading to real-world errors with incredibly serious practical safety implications. Let's dig into the psychology of this. Why is this misunderstanding so systemic?
It's mostly because of the emotional state of the patient at the exact moment the information is delivered.
What do you mean?
Think about it. When a patient is diagnosed with, say, advanced coronary artery disease, they are sitting in a sterile room wearing a paper gown and operating from a place of sheer terror and vulnerability.
Oh, absolutely. Total deer in headlights.
Right. And into that highly emotional, overwhelmed state, the medical system drops a dense, practically indecipherable payload of medical terminology.
Right. The doctor talks for maybe 7 minutes, hands them a prescription, and then the pharmacy hands them a plastic bottle with a massive piece of folded paper inside, covered in 8-point font.
Yes.
It's exactly like reading the terms and conditions of a software update for your phone.
That's a great way to put it.
You either ignore the massive wall of text completely and just blindly hit accept, assuming Apple wouldn't brick your phone on purpose, or you actually try to read it, get to the part where it says may cause sudden total data loss, and you get absolutely terrified to update your device.
It is the exact same behavioral psychology, but obviously the stakes here are human lives.
Right.
Let's look at statins again, the foundational medication for stabilizing that plaque we talked about. Statins are incredibly effective, but they have a well-documented, though relatively rare, side effect profile. They can cause myopathy, which is muscle pain or weakness, and in extremely rare cases, we are talking fractions of a percent, they can cause a severe muscle breakdown called rhabdomyolysis.
Hold on, let's explain the how here. If this pill is meant to lower cholesterol in my blood, why on earth is it dissolving my muscles? That sounds like a terrible trade-off.
It's a fascinating biochemical quirk. So statins work by blocking an enzyme in your liver called HMG-CoA reductase.
Okay.
This enzyme is crucial for the mevalonate pathway, which is how your body manufactures its own cholesterol. By blocking it, you lower cholesterol. But that same pathway also produces other compounds, including something called coenzyme Q10.
Oh, I've seen that in vitamin aisles.
Yep. CoQ10 is something your muscle cells use to generate energy. In some people, depleting CoQ10 or directly affecting the muscle cell membranes leads to cellular damage.
I see.
If the damage is severe enough, which is the rhabdomyolysis, the muscle cells actually rupture and spill their contents, including a protein called myoglobin, into the bloodstream.
And what does myoglobin do?
Myoglobin is very toxic to the kidneys. It physically clogs the tiny filtering tubules in the kidneys, leading to acute renal failure.
Oh, wow.
Now, I want to be incredibly clear. This is exceptionally rare. The absolute risk of a severe event is incredibly low, but the relative risk, compared to taking a sugar pill, does exist.
Okay, so let's walk through this. The patient unfolds that massive paper from the pharmacy. They scan it.
They read the label, they skip past all the clinical trial data they don't understand, and their eyes just lock onto the words severe muscle breakdown and kidney failure.
Naturally.
They don't have the context of frequency, they don't know the difference between absolute and relative risk, they just see the catastrophic possibility.
And what happens next?
A week later, they experience a completely normal, age-related ache in their shoulder from sleeping wrong, or maybe they just get sore from gardening.
And they blame the pill.
They immediately attribute it to the statin, they panic, and they unilaterally decide to stop taking the medication without ever consulting their doctor.
Wow. And the invisible toll of that misunderstanding is massive because no one tracks it until it's too late.
It's catastrophic. By trying to avoid a highly unlikely misunderstood risk of muscle pain, they have just exponentially increased their very real, statistically probable risk of suffering a fatal myocardial infarction.
The plaque ruptures.
The plaque they were trying to stabilize becomes active, it ruptures, and they die. The misunderstanding didn't just cause momentary anxiety, it dictated their survival.
So we really have to ask, whose fault is this? Is the biological information simply too complex for the average person with no medical background to grasp? Or is the delivery mechanism of this information fundamentally broken?
I'd argue it is entirely a failure of delivery and context.
Really, not just too complicated.
No, human beings are remarkably capable of understanding complex risk if it is framed correctly for them. The problem is that the information traveling from the clinical trial to the regulatory agency to the pharmacy label and finally into the patient's home loses all of its critical nuance.
It gets stripped away.
Exactly. Understanding who may be affected by a drug and why is the critical missing piece. A warning label might say a drug causes kidney toxicity, but it doesn't explain that this warning is primarily relevant for patients who already have impaired renal function.
Right, so a healthy 50-year-old reads it and thinks, this drug is going to destroy my healthy kidneys, when the biological reality is that their specific body, with a high filtration rate, is perfectly equipped to metabolize and excrete the drug safely.
Exactly. The warning is painted with a massively broad brush, but human biology is agonizingly specific. And when patients are left to bridge that gap between broad warning and specific biology completely on their own, the practical safety implications are terrifying.
Yeah, they might inadvertently combine dangerous elements because they don't understand the mechanisms.
Yes. Let's do a patient scenario to ground this.
Walk me through how a misunderstanding leads to an accidental, dangerous combination.
Okay, let's take John. John is 65. He was diagnosed with atrial fibrillation, the electrical chaos we discussed earlier.
The quivering heart chambers.
Right. So, to prevent a blood clot from forming in his quivering atria and causing a stroke, his cardiologist prescribes a modern blood thinner, an anticoagulant like apixaban. This is a brilliant life-saving medication. It works by inhibiting specific clotting factors in the blood.
Okay, so John's blood is now intentionally less prone to clotting.
Right. But John also has bad osteoarthritis in his knees. He's in pain. So without thinking about it, he goes to the drugstore and buys an over-the-counter NSAID, a non-steroidal anti-inflammatory drug, like ibuprofen or naproxen. He takes them every day for his knee pain.
Because it's over the counter, he views it as fundamentally safe. It's just Advil, right? What could go wrong?
Exactly. But let's look at the biology. NSAIDs work by blocking enzymes called CAOX1 and CAOX2.
Okay.
These enzymes create prostaglandins, which cause inflammation and pain, so blocking them stops the knee pain. But prostaglandins also have a massive protective role in your stomach.
Oh boy.
They stimulate the production of the thick mucus layer that protects your stomach lining from its own digestive acid.
Oh no. So by taking the NSAID for his knee, he is stripping away the protective armor in his stomach.
Yes. The stomach acid starts eating into the lining, creating an ulcer, which begins to bleed. Now, in a normal person, platelets would rush to the ulcer, form a clot, and stop the bleeding pretty quickly.
But John is on a potent prescription anticoagulant.
Exactly. The bleeding doesn't stop, it accelerates. He starts hemorrhaging into his gastrointestinal tract. He ends up in the emergency room receiving a massive blood transfusion, entirely because he didn't understand the mechanistic interaction between a prescription drug and a common drugstore painkiller.
Wow. He understood that one pill stops strokes, the other stops knee pain, but he didn't understand the how. He didn't understand the underlying safety profile of the entire ecosystem of chemicals he was putting into his body.
Precisely. And this is a perfect illustration of why the current system leaves the listener incredibly vulnerable. A misunderstood risk isn't just an academic error you get graded on. It is a real-world physical trauma. It dictates your daily quality of life. Are you living in a constant state of low-grade fear regarding your medication?
Many people are.
Are you abandoning a treatment that could give you 20 more years with your grandchildren because you misread a label? How is a patient supposed to find the middle ground between blind, passive acceptance and paralyzing fear?
Right. And to answer that, we have to pull back the curtain even further. We have to look at where these terrifying warnings actually come from. This systemic failure to communicate clearly leads us directly into exploring the broader regulatory context and how we compare different drugs. We have to understand the source code of the warnings.
Exactly. When the iMedix sources talk about navigating regulatory context, things like FDA black box warnings, specific contraindications, adverse event reports, we are talking about the raw data of patient safety.
Where does this data actually come from?
It starts with clinical trials, phase 1, 2, and 3 trials, which might involve a few thousand highly selected, closely monitored patients.
But a few thousand people don't represent the entire messy population of the planet.
They don't, which is why the most critical data often comes after the drug is approved. This is called post-market pharmacovigilance.
Pharmacovigilance, that's a mouthful.
It literally means drug watching. Regulatory bodies like the FDA collect adverse event reports from the millions of real-world people who start taking the drug. If enough people out in the real world report a specific issue that wasn't seen in the tightly controlled clinical trials, the FDA forces the manufacturer to update the label or add a warning.
Okay, so the system works. It finds the hidden dangers.
It works for gathering data, yes. It is vital for public health. However, this raw data is notoriously, almost aggressively inaccessible to the average person.
Because of how it's written.
Think about the language used. It is drafted by a committee of research scientists and pharmaceutical lawyers. It is written for other research scientists and other lawyers.
Right. Isn't it designed just as much to protect the drug manufacturer from liability lawsuits as it is to educate the patient? Like if they put every conceivable risk on the paper, you can't sue them when it happens.
Liability is undeniably a massive driver of how these documents are structured, and the result is an impenetrable wall of medical jargon that buries the actual actionable information.
Yeah, you just can't read it.
And this brings us to the importance of drug comparisons, which the iMedix protocol heavily emphasizes. If you don't understand the regulatory nuances, you cannot compare your options.
Why compare them? If they treat the same thing, aren't they basically the same?
Not at all. Why might two medications that are designed to treat the exact same heart issue have entirely different safety profiles or regulatory warnings?
Let's explore this deeply, because this is where the illusion of all pills are the same just shatters. Give us a biological example of how two drugs that do the exact same thing can have completely different baggage.
Let's look at beta blockers, which, as we discussed earlier, are foundational for treating both coronary artery disease and heart failure. They block the adrenaline receptors.
Right.
Now, you might have two different beta blockers. Let's call them metoprolol and atenolol. Conceptually, therapeutically, they both do the same thing. They slow the heart rate and reduce blood pressure.
Okay.
But the way they travel through and eventually exit the body, what we call pharmacokinetics, is radically different.
Okay, how so?
Well, metoprolol is lipophilic, meaning it dissolves in fat. Because of this, it is primarily metabolized or broken down and cleared from your body by your liver.
Got it. Liver.
Your liver uses specific enzymes, primarily the cytochrome P450 system, to chop the drug up so you can excrete it. Atenolol, on the other hand, is hydrophilic. It dissolves in water.
So it avoids the liver.
It essentially bypasses the liver and is cleared directly by your kidneys through glomerular filtration.
Okay, so drug A goes out the liver door, drug B goes out the kidney door. Why does that matter to the patient?
Because it changes the entire safety profile based on your specific biology.
Oh, I see.
If I am a patient with severely reduced kidney function, maybe I have diabetic nephropathy, or I've had high blood pressure for decades that damaged my renal filters. Atenolol, the kidney-cleared drug, could build up to toxic levels in my bloodstream. My kidneys simply can't filter it out fast enough.
And what happens then?
My heart rate could drop dangerously low. I could pass out.
While metoprolol, the liver-cleared drug, would be perfectly safe because your liver is functioning flawlessly and handling the clearance.
Exactly. So you have two drugs in the exact same class, achieving the exact same therapeutic goal for the heart, but they have completely different safety implications based on the individual metabolic variables of the patient.
That's crazy.
The regulatory warnings for the kidney-cleared drug will have strict dosage adjustments and warnings for renal impairment, while the liver-cleared drug might not.
But wait, how does a patient possibly know this? Conceptually, a patient just walks out of the clinic knowing I'm on a beta blocker for my heart. They don't know if they're on the liver-cleared one or the kidney-cleared one.
Usually they don't.
They don't know the phrase pharmacokinetics. So if their kidney function changes over time, or if they start taking another drug that stresses their kidneys, they are flying completely blind. They have no idea they are suddenly at risk. How on earth can a patient possibly keep track of this without a guide?
This raises an important question, perhaps the most important question in modern outpatient medicine. How do we take these vital, highly technical regulatory warnings, these complex clearance pathways, and actually translate them into actionable safety education for the patient?
Because right now, the system expects a 15-minute consultation with a primary care physician every 6 months to accomplish this. And it simply isn't enough time.
It is mathematically impossible. A doctor cannot sit there and explain the cytochrome P450 liver enzymes, the renal clearance pathways, the absolute versus relative statistical likelihood of myopathy, and meticulously cross-reference every over-the-counter supplement the patient is taking all in a 15-minute window.
Right. While also checking their blood pressure, listening to their heart, and typing into an electronic health record.
They cannot. It is a systemic failure of bandwidth. And so the patient goes home with the raw data, that folded piece of liability paper, and they are overwhelmed. They cannot rely on raw data alone, which brings the conversation directly to the specific solution provided in our source material.
Yes, this brings us to the iMedix solution and the whole concept of empowering patients through independent data. Because the sources we are looking at don't just point out the terrifying flaws in the system and leave us in despair. They introduce the iMedix platform as the bridge over this chasm of misunderstanding.
The sources outline iMedix as a comprehensive, independent medical information platform. It is built around a vast, interactive drug database and educational resources that are strictly laser-focused on medication safety, deciphering regulatory warnings, and answering complex treatment questions.
Let's talk about the word independent, because I think that is the absolute linchpin of the entire platform. Why is independence so crucial when we are talking about medical data? Don't pharmaceutical companies have a legal obligation to tell the truth about their drugs?
They have a legal obligation to disclose risks, yes, but think about the framing. If a patient decides to Google a new medication they were just prescribed, where do they usually land?
Usually a brand's website.
Right. They land on the pharmaceutical company's official website. These websites are fundamentally marketing platforms. They will list the required side effects, usually at the very bottom or spoken rapidly at the end of a video, but the architecture of the site is designed to highlight the benefits and the emotional relief of taking the drug.
So it's technically true but skewed.
The data is legally accurate, but it is not entirely objective in its presentation.
If they don't land on the pharma site, they land on a blog.
Exactly. They land on ad-supported health blogs or holistic medicine websites that prioritize sensationalism and clicks over actual clinical nuance. You get headlines designed to provoke fear.
Right, like the 5 hidden poisons in your heart medication. Click here to read more.
Precisely. Neither of those sources, the marketing site or the sensational blog, is providing objective, contextualized education. An independent platform like iMedix provides a space where patients can cross-reference medication risks without any external commercial influence.
They aren't selling the cure.
They aren't selling the drug, and they aren't selling a sensational narrative to get ad revenue. The data is objective. It is synthesized from the raw regulatory warning, the clinical trials, and the massive post-market surveillance databases, but it is stripped of the marketing spin and the fear-mongering. It exists solely to educate.
So what does an independent drug database actually do for a patient in practical terms? Because I can hear a listener thinking, okay, a database. That just sounds like a digital searchable list of the same warnings that are on my paper leaflet. How does that help me?
It is far more than a list. A properly constructed independent drug database functions as a critical, intelligent filter. It doesn't just hand you the raw data. It organizes the regulatory context. It allows you to actively compare similar drugs side by side.
Oh, like our beta blocker example.
Yeah.
You could pull up metoprolol and atenolol and literally see the liver versus kidney clearance highlighted.
Precisely. It translates the medical jargon into practical safety implications. It takes a terrifying phrase like may cause acute renal failure and adds the necessary context.
Like saying who is actually at risk.
Exactly. It might say, this risk is primarily associated with patients who have a pre-existing glomerular filtration rate below 30. It explains who is at risk for a specific side effect, so you don't have to guess in the dark if that warning applies to your specific biology.
That's amazing.
It clarifies the exact parameters of the medication so the patient can actually partner with their physician, rather than just passively receiving orders.
You know, it's like a Carfax report for your medications.
A Carfax report, I like that.
Yeah, think about it. When you buy a used car, you don't just look at the shiny paint job on the lot and say, looks great, I'll take it. You demand the Carfax.
Right.
You want the full history. Has it been in a crash? What are the hidden warnings? What are the maintenance records? And you want to compare it to the other car on the lot before you commit to putting your family in. This is essentially giving you the Carfax before you commit to putting a powerful chemical compound inside your biology.
That is a brilliant analogy. It gives you the history of the drug, the known collision points, which are the drug-drug and drug supplement interactions like the NSAID and the blood thinner we discussed, and the specific maintenance requirements like needing regular blood tests to check your liver enzymes.
Let's speculate on this for a second, because if we extrapolate the impact of this, imagine a world where every listener tuning in today had expert-level, independent, deeply contextualized information for their specific medications right at their fingertips. What would that actually do to the macro healthcare system?
The reduction in practical safety issues and subsequent hospital readmissions would be revolutionary. It would save billions of dollars and thousands of lives.
Just from avoiding mistakes.
Think about how many hospital admissions are due strictly to adverse drug events. A patient takes 2 drugs that interact. The interaction causes their blood pressure to plummet unexpectedly. They stand up, they faint, they fall, and they shatter their hip.
Oh, wow.
That is a massive, cascading physical and financial trauma that requires surgery, physical therapy, and months of recovery. But that entire cascade started with an informational blind spot.
It started because they didn't know the 2 pills in their hand didn't play nice together.
Exactly. If a patient uses an independent database to cross-reference a new supplement with their heart medication before they take it, and the database flags a severe interaction, they don't take it.
So the fall never happens.
The blood pressure doesn't drop, the fall never happens, the hip never breaks, the hospital bed stays empty.
It completely flips the dynamic of patient care. By utilizing these independent educational resources, the patient transitions from being a terrified, passive recipient of a medical protocol to an active, informed, and heavily armed participant in their own health journey.
Heavily armed with objective truth. And when you are fighting a multifactorial, highly complex enemy like heart disease, an enemy that operates on a biological, electrical, and structural level, objective truth is your most valuable weapon.
Which brings us to the synthesis of this entire deep dive. We need to pull all these overarching themes together because we've journeyed through incredibly dense territory today.
We really have.
We started with the immense biological definition of heart disease, the plumbing, the pump, the electricity, the valves. We moved into the psychological peril of misunderstanding risk, through the dense regulatory maze of clinical trials and pharmacokinetics, and finally into the solution of independent data.
When we synthesize the core message of the iMedix protocol and the platform's broader mission, one undeniable truth emerges.
What's that?
Answering the massive, hopeful question of whether heart disease can be reversed requires, as an absolute prerequisite, an educated patient.
You literally cannot separate the two. You cannot have biological reversal without informational clarity.
You cannot. The hurdle to improving cardiovascular health is not just a biological hurdle. It is not just about inventing better surgical techniques or synthesizing new chemicals. It is an informational hurdle.
Right.
True, measurable progress, whether that is stabilizing a volatile plaque in your coronary artery, reversing the hypertrophic remodeling of your heart muscle, or safely managing an irregular heartbeat, is only made when a patient fully understands their specific treatment path.
They have to know the why.
They must understand the tools, the exact associated risks, and the mechanistic reasons why they are taking a specific action.
Because if they don't have that context, they will eventually stumble in the dark. They will unilaterally stop a life-saving statin because their shoulder aches, or they will add a dangerous, unregulated supplement out of a false, internet-fueled hope for a miracle cure.
Exactly. Addressing these real-world misunderstandings is the ultimate prerequisite for any successful health protocol. A cardiothoracic surgeon can perform a flawless, brilliant quadruple bypass. A leading cardiologist can prescribe the absolute perfect bespoke regimen of medications.
Wow.
But if the patient goes home and fundamentally misunderstands how to manage that regimen because they lack independent context, the intervention will ultimately fail. The plaque will return. The heart will fail.
If we connect this to the bigger picture, what does this say about the future of medicine?
If we connect this to the bigger picture, Platforms like iMedix that clarify these risks and decode the regulatory landscape are no longer just optional, nice-to-have resources for the hyper-curious patient. They are essential pillars of modern healthcare.
Essential pillars. I like that.
They protect the patient against the ultimate danger in medicine today, which is not the disease itself, but the danger of misinformation and misunderstanding regarding the cure.
So what does this all mean for you, the listener? It means that taking control of your health and genuinely exploring the possibility of halting or functionally reversing a chronic condition like heart disease does not start with a miracle cure you found on a late-night blog.
It definitely doesn't.
It doesn't start with a sledgehammer approach. It starts with a relentless, meticulous commitment to eliminating the misunderstandings about the very tools you are using to fight the disease. It starts with treating information with the exact same level of respect and caution that you treat the physical organ beating in your chest.
You absolutely have to unpack the information before you can even hope to reverse the disease. That is the genius behind the protocol's title, and it is the uncompromising reality of patient care today.
As we wrap up this deep dive, let's just briefly reflect on the immense territory we've covered. We started with the broad, culturally loaded, and dangerously misleading question of reversing heart disease.
Right, getting past the catchphrase.
We broke that down into its complex biological realities. The inflammatory clogging of the arteries, the mechanical exhaustion of the muscle, the chaotic misfiring of the electrical system, and the physical degradation of the valves.
Yeah.
We realized that true clinical reversal requires pinpoint diagnostic accuracy. You have to know what is broken before you can fix it.
And then we navigated the incredibly dangerous landscape of patient misunderstanding. We explored the deep cellular mechanisms of how drugs work and how the fear of rare, poorly contextualized side effects like statin-induced muscle breakdown can drive patients to abandon life-saving therapy.
It's so tragic when that happens.
We saw how the current medical delivery system often fails to bridge the crucial gap between raw, lawyer-approved regulatory data and actionable, personalized patient knowledge.
And finally, we arrived at the empowering solution. We explored how independent drug databases and dedicated educational platforms, completely free from commercial spin and clickbait fear-mongering, act as the ultimate filter. They translate the impenetrable wall of medical warnings and pharmacokinetics into a clear, personalized map for survival.
It represents a profound, necessary shift from a paternalistic model of medicine, where you just swallow the pill you are handed without understanding why, to a collaborative, empowered model where your informed consent is actually genuinely informed.
It is a totally new way of looking at your own healthcare and your own agency within it. And as we leave you today, I want to leave you with one final thought to mull over. Building on everything we've unpacked here, we've spent this entire time exploring how understanding the exact safety profile, the hidden clearance pathways in your liver and kidneys, and the regulatory warnings of your heart medications is step one in tackling something as massive as cardiovascular disease.
It's the critical first step.
But it leaves you wondering, what other daily medications or seemingly harmless over-the-counter supplements are sitting in your cabinet right now? Perhaps they are for entirely different conditions, your thyroid, your allergies, your joints. But they're sitting there carrying incredibly complex regulatory contexts, chemical interactions, and safety implications that you've completely misunderstood or ignored because the font was too small to read. Tomorrow morning, when you open that door and look in your medicine cabinet, will you just see simple binary pills and plastic bottles? Or will you see an entire database of unpacked information, an entire ecosystem of biological interactions just waiting to be understood